Hello, everybody, and thank you for joining us again for another one of our Meet the Specialist sessions. Today, we are joined by the lovely Associate Professor Louis Izzo, who is an obstetrician and gynaecologist of some renown. He's also worked in the medico-legal field for many, many years and is highly respected for his outstanding reports. So without further ado, Dr. Izzo, I'll hand over to you. You can talk a little bit about what you do, what your interests are, and so people can get to know you a bit. Thank you.
Fair enough. What a wonderful introduction. Thank you very much. So, yeah, as was said, I'm an obstetrician and gynaecologist based in Sydney. And I, in fact, am still active in that I head the department of two hospitals. One is called Concord Hospital, the other one, which only has gynaecology. The other one is Canterbury Hospital, which has both obstetrics and gynaecology. And I also work at Royal Prince Alfred, which is one of the sort of principal hospitals in Sydney, the tertiary hospital, certainly for O&G. So, yeah, and all this sort of came about, I suppose, medico-legal work about 20 years ago. Up until that time, I was doing a lot of private obstetrics, between 500 to 600 deliveries a year, which meant that, one, I was never home, and most nights I was up all night. And after a while, I thought I need to sort of rebranch into something else. And so I was always interested in medico-legal work, and so I started doing that. I originally started with the University of New South Wales and was doing some work for them. So nowadays, about, I suppose, 70% of my time is involved in medico-legal work. About 20% is involved in teaching because I'm a senior lecturer at Sydney University and associate professor at Notre Dame, which involves a fair bit of teaching with medical students. And also I have been for many years a teacher and mentor to specialists or trainee specialists, both preparing for their OSCE and written exam, and in fact have been an examiner for those two exams and sort of setting up questions and so forth. So, yeah, the other thing that I do with the college is that I involved with SIMG, which is part of the college which accredits our overseas specialists. So if a specialist is trained overseas, we look at what they've done and we grade them, whether they are at the level that they can work in Australia or they need some further training and so forth. So that's been very interesting. All right. Now, so the medico-legal work, basically, so as I said, I started about sort of 20 years ago, and initially, because I am bilingual, my parents Italian, I was born here and did all my schooling and undergraduate work here and so forth. But through my parents, I also have citizenship in Italy and Australia. Now that proved very helpful about 20 years ago, where I was asked to work in Milan for 2 years, and because they at that stage had very little approaches to registering complications and so forth. And so that was set it up in the University of Milan and through the hospital there. And then from there, I had another even more interesting time that I worked in Geneva for 2 years, working with women that had been part of civil war, where there'd been atrocities, rapes, and so forth. It was, again, very interesting, but a very difficult time, and also involved in women where their babies had been taken at birth and things like that. And that, in fact, led on to the work when I came back to Australia about 16 years ago. Initially, I was involved in both Aboriginal and white women where their babies had been taken at birth. And after many years, and this was very common, unfortunately, in 15 or so years ago, and the consequences have been that a lot of these women have had lives that have been destroyed, and so they were seeking some sort of compensation, often from the church and from government bodies, and I was involved in that. Then with that, I sort of came down to earth a bit, and the sort of things that I do nowadays, I first of all am gynaecologist for the Department of Transport, motor vehicle accidents and so forth. Not that an enormous amount of it involves gynaecology. It mainly involves orthopedics and so forth, but I've been involved with that and with workers' compensation. I've worked on both sides of the fence in that I've worked for the government and a number of medical boards throughout Australia, Western Australia to a great extent, looking at doctors to see what their work is like and whether they're capable of still working. And that was through the medical board. Then that moved on to, I was involved there were a number of cases of people who were in prison, and there was sort of a number of mainly sort of rape cases and incest cases, and we're looking at to see whether the judgments were correct or not. I was involved in that. Nowadays, I suppose the majority of my work, even though I work still for medical boards, I work for Medical Defence Association, but probably 80% of the work involves patients and women themselves. And this is both in obstetrics and gynaecology. And one of the things which has sort of started to develop, which is really not good, is that there seems to be, if we look at gynaecology for a moment, an enormous amount of complications arise. Now, complications are part of work, a part of operating. Unfortunately, a lot of it has got to do with lack of patient's understanding, so poor consent mechanism, and also complications during the surgery. Nowadays, most gynecological surgery is done via laparoscopy, and a lot of the surgeons who do this sort of work do really not have the adequate training, and thus they have a high risk of complications of bowel and bladder and bleeding and so forth. And part of the problem is when the complications arise, they do not acknowledge it, and then there's a significant delay till matters are sorted out, and then often it's too late to be able to do any sort of definitive repairs and so forth. I lately have been involved, with MESH, I've been involved for a number of years, but now I'm starting to get involved. This is in class actions, and now starting to get involved in a thing called Assure, which you may or may not have heard of. Assure was not widely used in Australia, but there were some 5,000 women that had Assure, which was like a little plug that was put into the uterus as a method of permanent contraception, and it ended up being a disaster. A lot of women had problems that they ended up having to have hysterectomies. A bit of this coil, which is what it was, broke off, and other women had nickel poisoning because it was made of nickel, and the nickel was deposited in their body. So it really has a terrible history. Then finally, we move on to obstetrics. And obstetrics, again, has its own significant problems. So when one looks at what actually has occurred in the case, I make a point of not looking at the end. So I read from the beginning, not to see what the end result is, and you can pick it almost immediately where things have gone wrong. And this is in the antenatal period, the lack of monitoring or not understanding monitoring. And then there's a whole thing which revolves around delivery, women wanting cesarean sections and not able to have them because the doctor refuses, all the problems associated with forceps delivery, and there are numerous ones of those, and tears as well. And so really, no one should end up having a third or fourth degree tear. Somewhere along the line, there's been mismanagement. And here we have tears that are missed, tears that occur, and tears that are not properly sutured. So it's an enormous area. And unfortunately, when this occurs, women are stuck with it for the rest of their lives. And if you look at the cases that I've seen, and I probably do about 2 to 3 a week, these women end up having multiple operations in an effort to repair the damage which was done initially, and very rarely do they get a satisfactory outcome. On a practical level, what I do is if someone sends a case to me, I say to them, all right, what I think we should do is that you should send me at least the details of the case and what you think of it. Then what I do is that I have a telephone conference, because I think this is important, because either there isn't much in it, or so that people can understand what the whole concept of the case is. And for that, I either don't charge or charge very little. And I think it's unfair at this stage, but because of course the money in some way will probably come either from the insurance or from the patients if things do not go well. And so I think it's important to make that initial sort of entry point something which is affordable. If after that a decision is made by the patient, by the legal firm and so forth, that they want to go ahead with a formal report, then that's sort of done, and it's done. I do it on an hourly basis, and really try to make an effort to keep the costs down as much as possible, because I know that it becomes very expensive with all the ancillary costs. Finally, from a time point of view, because 70% of my work is involved that, I've got a secretary that is fantastic to organise my life, and also the typing and everything else. Most cases, a turnaround time is very quick. Usually 2 to 3 weeks occasion, but usually about 2 weeks. And if it's really urgent, we can even do it within a week. So yeah, that's kind of it in a summary. So basically, I cover pretty much all areas of sort of O&G, and you know, I'm just horrified by the number of cases which should never have occurred. And so, you know, I mean, I think if a complication occurs and it's appropriately dealt with, and that's fine. I mean, that's life, you know, as long as it's been explained to the patient beforehand. But in most cases, you know, things go terribly wrong, and they shouldn't, because most of these things are very straightforward, and really, there's really no excuse for creating the problems which women end up with. That's it.
Thank you so much, sir. That was very comprehensive, encompassing the work that you do, but also the work that you do with and for us, for which we are very grateful. And I agree, we see some absolutely devastating effects of failure to consent, failure to agree to cesarean sections, and various other procedures, almost as if women are guinea pigs sometimes.
That's right.
To those of you who've joined us, do any of you have a question that you would like to ask? If you could unmute yourself if you have a question. Okay, no questions. Now that is usually because you've been so comprehensive, but I do have one question from a person who has not been able to attend. It's a plaintiff lawyer, and they are asking whether you are seeing an increase in complications where women are choosing not to involve an obstetrician in their primary pregnancy care and to instead go with a doula or midwifery.
So I think, look, obstetrics is a unique area of medicine where doctors work in conjunction with midwives. You don't see this in any other area of medicine, because the doctors sort of are in charge, control the show, and whether they're theatre nurses, whether they're nurses in the wards, they really have minimal input. What has happened over the years is that what most hospitals have is a system of triage. And I do this in the hospitals I am because I get the most senior person. And when a patient comes in, I triage them to low risk, medium risk, and high risk. And this also poses a great problem in that a lot of the patients where things have gone wrong have been classified as low risk when they should not have been classified as low risk. And they should have been seen by the obstetrician on each visit, and not just the midwife, and definitely not a doula. One of the things that has changed over the years in hospital practice is, and it's a good thing, is that there is a very close scrutiny of everything that's done. When you have someone outside the hospital system, and doulas are outside the hospital systems for a number of reasons. One, because they didn't want to be in the hospital system. Two, because the hospital system kind of, in the way that they managed, just rejected them, which was wrong. And so there's none of these checks and balances. And so unfortunately, I find most of the complications occur where there is minimal supervision, and that's the sort of situation where it occurs. So, I mean, I think midwives looking after in patients in conjunction with the doctor, and nowadays we have some marvellous models, such as a midwife who looks after them all the time and then is there for the delivery, and that's fantastic. But you have to have a good relationship between the doctors and midwives. If it breaks down and both sides are to blame, then I think complications do arise, and they certainly have gotten worse, yes, and more common.
Thank you so much for that. Everyone, thank you for attending with us today to get to meet the very lovely Dr. Izzo.
Thank you so much.
Look forward to seeing that you invite him to consult on your matters and give one of his beautiful reports. Thank you, sir, for your time today. For everybody, the recording of this will come out to you within the day or so, and it will be up on our YouTube channel for you and your people to watch so that you can all get to know the lovely Dr. Izzo a little bit better. Thank you so much, sir.
Thank you so much. Thank you. Thank you.
Have a great rest of the day.
Thank you so much. Bye.
Bye.